Yeah. Welcome all to the today's session. So today we are going to continue with our antenatal module, and the topics which will be covered are shoulder dystocia and postpartum hemorrhage, green top guidelines. Then we have preterm labor, PPROM, and we also have postnatal care NICE guideline, and also postmortem caesarean section. So we begin with our session with our tagline, that is Master MRCOG with concept oriented clarity. Hope my lectures will clear your concepts and you will be able to clear your part 2 soon. So what is the definition of shoulder dystocia? It is a vaginal cephalic delivery which needs additional maneuvers after the delivery of the head and gentle traction for the delivery of the body fells. Okay. Another definition which is proposed with respect to time is when more than 60 seconds are required for the delivery of the body after the delivery of the head. Okay. And it is caused mainly by the impaction of the anterior shoulder. Very rarely you get the posterior shoulder impact. Okay, impacted posterior shoulder. So what is the incidence? Incidence is 0.6% or 0.58 to 0.7%. We have seen one more condition where there is an incidence of 0.6%. Anyone knows other condition what we have seen before, which has got
Ectopic pregnancy.
no, ectopic is not 0.6%. Last lecture you have not attended, because this incidence we have covered cord prolapse. Cord prolapse has got a 0.6%. Okay, ectopic has
Yes, sir.
11 per 1000. Okay, and
Yes,
different
sir.
population difference. Okay, so coming to the maternal complications, PPH is seen in 11% of cases. Then third and fourth degree penile tear is seen in 3.8% of cases, and this is not affected by the irrespective of the type of manure which you are doing. Okay, so we know shoulder dystocia has got a many manures, but irrespective of the type of shoulder dystocia, this incidence third to fourth degree is around 3.8%. So postpartum hemorrhage is around 11%, third fourth degree tears around 3.8%. Then the most important fetal complication is brachial plexus injury, which is around 2.3 to 16% cases of shoulder dystocia. Less than 10% cases of brachial plexus injury will lead to permanent neurological deficit, and this brachial plexus injury is one of the common cause for the litigation. This is also SBA. Okay, so up till now SBA can be incidence of the PPH in this. Then maybe definition they can ask you, but here you have one brachial plexus injury, which is one of the common cause for the litigation. So medical legal aspect, brachial plexus injury is the most common litigation cause in shoulder dystocia and third most litigated obstetric complication in UK. Okay, so NHS litigation authority says 46% of injuries are linked to the substandard care. This is also one of the SBA, but this we will be covering in the clinical governance. Okay, so coming to the brachial plexus injury without shoulder dystocia. Okay, so this brachial plexus injury can also happen without shoulder dystocia, which is seen in 4% cases of caesarean section, and another series is mentioning about 12%. Okay, now can we predict the shoulder dystocia? Okay, so in general, clinician must be aware of the risk factors and stay alert in all labors. Current risk assessments are poor predictors of and cannot prevent most cases. So actually there are prediction models, but they are not recommended. Okay, because most of the shoulder dystocias are not associated with the high risk factors which have been identified. There are high risk factors, but most of the shoulder dystocias are not associated with these high risk factors. So risk factor or predictive risk factor predictive value. What is the predictive value of risk factor? So the risk factors are divided into antenatal and the intrapartum factors, and they have a low positive predictive value. Conventional risk factors predicted only 16% cases of shoulder dystocia. So knowing the and being no doubt we have to be alert, but that is not only that is not sufficient when you are dealing with shoulder dystocia. So these factors are divided into pre-labor factors and the intrapartum factors. So pre-labor factors are previous shoulder dystocia, then macrosomia, where there is a birth weight of more than 4.5 kg, diabetes mellitus, maternal BMI of more than 30. Okay, induction of labor. So these are the pre-labor factors. Then intrapartum factors like prolonged second stage, prolonged first stage, or secondary arrest, then oxytocin augmentation and assisted vaginal delivery. So these are the intrapartum factors which are associated with the shoulder dystocia. Now let's see the effect of various factors like fetal size. When there is a large fetal size, will it increase the chance of shoulder dystocia? Okay, the large fetal size will increase, but not a reliable predictor. Many infants more than 4.5 kg do not develop shoulder dystocia. So definitely there will be some increase, but it is not a reliable predictor because most of the infants more than 4.5 kg do not have a shoulder dystocia. Then infants less than 4 kg, 48% cases of shoulder dystocia cases occur in infants less than 4 kg. So that is why no doubt the fetal size will increase, but that cannot be said as a reliable factor. Okay, then coming to the diabetes, infants of diabetic mother. Now here in diabetes there is a 2 to 4 times higher risk than the non-diabetic mothers of the same birth weight. Okay, so diabetic mothers definitely have 2 to 4 times high risk of having shoulder dystocia at the time of delivery. Then there are predictive modeling like considering into maternal height, weight, gestational age, parity, birth weight, fetal weight estimation, etc. But these factors, these models are not recommended. Okay, so sensitivity for these factors is 60% for macrosomia, but the errors are known with this, so they are not recommended. Now coming to the prevention of shoulder dystocia. So can induction of labor will help in these cases? So let's see what the guidance is. So if you have a non-diabetic mother with suspected macrosomia, then induction of labor does not prevent shoulder dystocia, no improvement in maternal or fetal outcomes. Okay, for non-diabetic mother with suspected macrosomia, there is no role for the induction of labor. For women with gestational diabetes, induction at term reduces the incidence of shoulder dystocia. What does the NICE guidelines says? Offer induction or elective caesarean section after 38 weeks for women with diabetes and normally grown fetus. Okay, so termination of the pregnancy around 38 weeks of gestation, either by induction or elective caesarean section in gestational diabetes, will definitely reduce the incidence of the shoulder dystocia. So there is a difference between non-diabetic and diabetic recommendation. Okay, is it clear with respect to the macrosomia and induction of labor? Is it clear?
Yes, sir.
Yeah. So
Yes, sir.
next, we continue with the prevention of shoulder dystocia, elective caesarean sections. So pregnancies with pre-existing or gestational diabetes mellitus, if the birth weight is more than 4.5 kg, then elective caesarean section may be considered. Okay, consider elective caesarean section to reduce the morbidity. Diabetic mothers have 2 to 4 times higher risk of shoulder dystocia than non-diabetics of same birth weight. Okay, so that we have seen just now at the time of induction of labor. Then mode of delivery after previous shoulder dystocia. So last delivery, when there is a shoulder dystocia, how the labor should be managed? So should we recommend caesarean section in that particular case, or should we can she have vaginal delivery? So what does the guideline says? Either caesarean section or vaginal delivery may be appropriate. So it is not an absolute indication for caesarean section. Either caesarean section or vaginal delivery, no doubt there is going to be a shared decision making. Okay, so decision making should be made jointly with the woman and her carers. The what is the risk of recurrence? Okay, women with previous shoulder dystocia have a 10 times higher risk as compared to the general population. So there is a definitely higher risk, 10 times higher risk for the recurrence. So this can be asked as a SBA. Okay, there was a history of shoulder dystocia and the patient has come for the antenatal deciding regarding the mode of delivery, and she is asking you what is the going to be the recurrence rate if she has got a previous shoulder dystocia. Okay, so recurrence rate other is 1 to 25% may be over estimated due to selection bias from caesarean section after severe cases. So there is a wide range because most of the patients will undergo caesarean section with a previous shoulder dystocia. So the falsely there may be reduced incidence also. Now what is the role of elective caesarean section? Not routinely required. Consider severity of previous injury, predicted fetal size, maternal choice, etc., etc. So elective caesarean section not routinely required. Okay. Now preparation in labor. Now coming to the management of shoulder dystocia. First thing, preparation in the labor. All birth attendants must know the signs of shoulder dystocia and delivery techniques. Second, look for difficulty delivering face, chin. Look for the turtleneck sign, that is the head is tightly applied or gets retracted after the delivery, and failure of the restitution you can notice, and failure of the shoulder to descend. Now, what is the guidance regarding the traction? This is one of the important thing which you should remember. Use always axial traction that is in line with the fetal spine. So traction should be axial traction in line with the fetal spine for diagnosis, and it should be a routine traction. Okay, it should not be excessive traction. It should be routine axial traction, and avoid lateral or downward traction. So this is very important when you are diagnosing shoulder dystocia. It should be axial traction in line with the fetal spine, and lateral and downward traction is to be avoided. So routine versus axial traction. Routine traction standard for uncomplicated births. Axial traction, should not be any lateral deviation. Avoid lateral and downward traction, which increases the risk of nerve injury. Downward traction linked to the residual brachial plexus injury at 18 months. Okay, so downward traction has got a association with the brachial plexus injury. Then MRCOG maneuver before head delivery, will it help? Before delivery of the head, MRCOG is not indicated. So MRCOG is the maneuver of first choice after the development of the shoulder dystocia, once you diagnose, but not before the delivery of the fetal head. Okay. Now coming to the management of shoulder dystocia, what are the principles? We have to go as per the algorithm. First is always call for help. Okay, you have to state this is a shoulder dystocia. Okay, you have to call your team. The first maneuver will be MRCOG maneuver, which is going to be simple, rapid, and effective. Add suprapubic pressure to improve the effect. Suprapubic pressure is also called as Rubin 1 maneuver. Okay, so MRCOG, Rubin 1 is combined with the MRCOG. The first is a MRCOG, then comes the Rubin 1. These are simple, rapid, and effective first line techniques. Okay, what is to be avoided? Avoid fundal pressure, because it will increase the complication. Possibility of uterine rupture will increase. Then maternal pushing is to be avoided. It will worsen the impaction. Then what is the role of episiotomy? Okay, you have diagnosed shoulder dystocia, but what about episiotomy? Only if needed to facilitate the maneuver. Okay, episiotomy is given only if it is required to facilitate the maneuvers. The timing and outcomes, 47% of the deaths occurred within 5 minutes of the head delivery. Most had an abnormal CTG before dystocia. Okay. Then team members to summon are additional midwifery staff, obstetrician, neonatal team should be ready, anesthetist you need to call. What is the benefit of communication? Early declaration improves the outcome in shoulder dystocia and other obstetric emergencies. Now this MRCOG maneuver, as we said, is going with the first maneuver. It is a flexion and abduction of maternal hips, that is the thighs on the abdomen. How does it help? It straightens the lumbosacral angle, rotates the pelvis upward, and increases the anteroposterior pelvic diameter. Okay, so this also you should know. It is a flexion and abduction of the maternal thighs. Then it will help by straightening the lumbosacral angle. It rotates the pelvis upwards, and it increases the anteroposterior pelvic diameter. Okay, so efficacy is up to 90%. This is one of the SBA which is asked, what is the success rate of this MRCOG? It is 90%. Okay, low complication rate and first line maneuver. So lay women flat, remove the pillow. Two assistants will hyperflex. You need to remove her legs from lithotomy stirrups and apply routine axial traction to fetal head to check release of anterior shoulder. Okay, and if unsuccessful, we'll proceed to the next maneuver. So this particular maneuver has got a success rate of 90%. Okay, now suprapubic pressure, also called as Rubin 1 maneuver. It is often combined with the MRCOG to improve the success rate. It reduces the bisacropeal diameter, rotates the anterior shoulder into oblique diameter. So this is what is the mechanism. What we have seen the mechanism in MRCOG was it increases the anteroposterior diameter. Lumbosacral and it will straighten the lumbosacral angle, this MRCOG maneuver. Okay, while this suprapubic will reduce the bisacromial diameter and it will rotate the shoulder into oblique diameter. So application, how it should be applied? It should be applied from the side of the back. So from the back side you have to apply downwards and lateral just above the symphysis pubis. Okay, downwards and lateral just above the symphysis pubis from the fetal backside. You may give it in a continuous manner or you may be giving it in a rocking pressure type. Both are equally effective. Okay, only routine traction on fetal head during the assessment. So during the assessment you are seeing that whether the shoulder is getting delivered, so you need to give traction. That traction should be routine traction during the assessment. Okay, if unsuccessful you will go for another. Then episiotomy does not relieve the bony obstruction. Consider only if your hand, you can pass your hand for internal maneuvers. This is difficult. If you are finding your hand is, you want to go ahead with the internal maneuvers and your hand access is difficult, then episiotomy will be helpful. Okay, it does not reduce the risk of brachial plexus injury. So episiotomy does not have a role in reducing the brachial plexus injury. It will not relieve the bony obstruction, but it will help us to carry out internal maneuvers if you have a difficult access doing internal maneuvers. Okay, now these two maneuvers, that is MRCOG and Rubin one has failed. Then what we have is a second line. In second line we have one all four positions and second is an internal vaginal maneuver. So what you can do is all four position. Okay, so it gives access to the sacral hollow, bring woman to the bed edge or remove the end of the bed, and woman on hands and knees. Okay, she will be on the in all four position, woman will be on hands and knees, while internal maneuvers will give us the access to the posterior vagina, then bring woman to the edge or remove the end of the bed. Then in internal rotation we have Wood's maneuver and Rubin's maneuver, that is Rubin 2. Okay, so what we do, rotate the shoulders into oblique diameter, pressure is given on the posterior shoulder to adduct, and delivery of the posterior arm can also be done. You need to grasp the fetal wrist and withdraw arm straight to reduce the shoulder diameter. While in all fours, no specific internal manipulation. It relies on the gravity and maternal position to free the shoulder. Okay. What is the success rate of internal maneuvers? It depends on the skill and experience of and case severity. While all four position has got 83% success in one of the series. So this can also be asked. Up till now they have said MRCOG 90%. Here what we have come across is all four position 83% success. Okay. Internal maneuvers, less mobile women and those with epidural, you can use these patients, but all four it is difficult for those patients who have got a epidural. Okay. Then what is the risk? Humeral fracture risk is around 2 to 12% with internal maneuvers, usually linked to the severe cases, and there is a minimal procedural risk in all four positions. Okay. Now this is the way the flow chart will go. You need to recognize, call for the help, obstetric, anesthetic, neonatal and senior staff, stop maternal pushing, no fundal pressure to be given. Then we will use first line maneuvers, that is MRCOG or suprapubic, that is hyperflexion of the maternal thighs, and in suprapubic dislodge the anterior shoulder. Then second line maneuver, that is internal maneuver, that is you can go ahead with the Rubin's 2, Wood screw or reverse Wood screw, or the delivery of the posterior arm. Okay, so these are the things what you can do in the second line. And no doubt all fours position is also there, but that they have included all fours position is also here. So this actually is here. Okay, and in third line the clavicular fracture, intentional clavicular fracture you can do, that reduces the shoulder width. Then you have Zavanelli's maneuver, you have to flex and replace the head, and then you carry out this immediate caesarean section. Okay, so this is very rare. Okay, then symphysiotomy, rarely used, pelvic enlargement in extreme cases. So these are the maneuvers which are used, or the flow chart for the management of the shoulder dystocia. Now let's see in detail about these maneuvers. First is a MRCOG maneuver. You need to hyperflex maternal hips onto the abdomen. It straightens the lumbosacral angle, rotates the pelvic scaphoid, and increases the pelvic outlet diameter. Okay. Then suprapubic pressure, that is Rubin 1. It is to be applied downward and lateral pressure just above the pubic bone and not the fundal pressure. Okay. Aim is to push the shoulder into oblique diameter. It helps to dislodge the anterior shoulder from behind the pubic symphysis. Usually it is combined with the MRCOG. Okay. Then what we have internal maneuver, Rubin's 2. In Rubin's 2, what we have to do is you will insert the hand into the vagina to reach the posterior aspect of the anterior shoulder. Remember, posterior aspect of the anterior shoulder. Apply pressure to the adduct the shoulder. It reduces the bisacromial diameter and facilitates rotation into the oblique diameter. So up till now, we were dealing with only anterior shoulder. In Rubin 2, it is a internal vaginal maneuver in which you are giving pressure over the posterior aspect of anterior shoulder. Okay. Up till now, we have dealt with the anterior shoulder only. Okay. Now see the wood screw. What you do in wood screw, the hand applies pressure to the anterior aspect of posterior shoulder. Okay. So here, the first time we are dealing with the posterior shoulder. So the pressure is applied to the anterior aspect of the posterior shoulder. It rotates the shoulder like a screw into the wider pelvic diameter and increases the chance for the delivery. Okay. Now reverse wood screw is also same. It will deal with the posterior shoulder only, but the pressure is applied on the posterior aspect of posterior shoulder. Okay. Opposite to the direction of the Wood's maneuver, it will rotate the fetus in reverse direction. Okay. The next is a delivery of the posterior arm. Insert the hand along the fetal chest to locate the posterior wrist. Swim the arm across the chest and deliver it out. Reduces the shoulder to shoulder diameter by 2 to 3 centimeters. So approximately by the width of the arm, this impaction will be relieved by around 2 to 3 centimeters. The next maneuvers here they have included into third line. Gaskin maneuver. You can move the mother onto her hands and knees. Then it changes the pelvic orientation, increases the pelvic diameters, may release impacted shoulder. But this maneuver is used mainly in the community setting. Okay. When single midwife is there, if you go through the guideline, they say that all force is suitable for a single person. Okay. Then clavicular fracture, intentional clavicular fracture. Apply controlled pressure to the fetal clavicle to fracture it, reduces the bisacromial diameter, and last resort when other methods fail. Okay. The next is the Zavanelli's maneuver. It flexes and gently replaces the fetal head into the vagina. Prepare for immediate caesarean delivery. It is very rarely performed. Then next is a symphysiotomy, surgical division of the symphysis pubis cartilage, expands the pelvic diameter and rarely used in modern practice, reserved in extreme cases. So now what is the if there is a persistent failure of the first and second line maneuvers, just now we have seen the clerotomy, symphysiotomy, Zavanelli's maneuver. Okay. Bilateral shoulder dystocia, sometimes they can ask you this Zavanelli maneuver may suit rare bilateral shoulder dystocia. Okay. But the condition itself is a very, very rare. Other methods are posterior axillary sling. There is a limited evidence. Okay. So that is what about the first line, second line, and third line. Now, what about the after the shoulder dystocia, the management? Okay, regarding maternal management, we have to be very vigilant to manage the PPH because 11% cases are likely to have postpartum hemorrhage and severe perineal tears. Around 3.8% cases there can be vaginal tears. Other possible complications will be vaginal and cervical tears, bladder rupture, uterine rupture, pelvic joint injuries, and neuropathy. For baby, neonatal clinician to examine for the injury. Common injuries are brachial plexus injury around 2.3 to 16% of cases. Others are humerus fracture, clavicle fracture, pneumothorax, hypoxic brain injury, and we need to communicate the events to the parents. Okay. What is the optimal management of shoulder dystocia? demonstrate the manuals in direct view, too complex for description alone, use high fidelity training program. These are not for the examination, but they will ask you what kind of team training will be required. So simulation training will improve the performance. Okay, so this particular thing, you remember that you are the team leader and you have been asked to decide or train your team regarding the shoulder dystocia manuals. So simulation training is going to be the helpful. Okay, before training there is a 43% success rate within 5 minutes. After the training the success rate doubles around 83%. Again, these figures will not be asked, but the type of training is a simulation training, and training should be multi-professional with practical demonstration using RCOG algorithm. So this particular one is a simulation training, and second is a multi-professional with practical demonstration using RCOG algorithm. Okay, so these can be the options for your question. Okay, and finally you need to document. Okay, what was the time of the delivery of the head baby, anterior shoulder at the time of dystocia, manuals which were used, etc. So this all documentation is required. This documentation and debriefing you need to discuss in the part 3 when you are having role play station. Okay, so that finishes our first topic of shoulder dystocia. Thank you. You understood the questions which can be asked on this particular topic?
Yes, sir.
Yeah. So we go ahead with our second topic, prevention and management of postpartum hemorrhage. This topic is going to be very, very important for part 2 examination, also for part 1. Also, many questions they are asking on this topic. So prevention and management of postpartum hemorrhage, it is a green top guideline number 52. So first, as usual in green top guideline, what we have is executive summary recommendations regarding the prediction and prevention of postpartum hemorrhage. What are the risk factors? They may be antenatal or intrapartum. Care plans should adapt as risk factors emerge, and known risk factors. If the patient is known to have some risk factor, it is better to deliver in a hospital with on-site blood bank. Okay, so these patients should be guided to have a hospital delivery. Then how will you minimize the risk? Treat antenatal anemia to reduce the morbidity. Uterine massage not useful for prophylaxis. Remember, for prophylaxis of postpartum hemorrhage, uterine massage does not have any value. Yes, prophylactic uterotonics are recommended in the third stage of labor. Vaginal birth without risk factor. So if you have low risk patient, who this is also frequently asked SBA, if you have a low risk patient, then the prophylactic uterotonic of choice for vaginal birth is oxytocin 10 units intramuscularly. Okay, so oxytocin 10 unit intramuscularly for vaginal birth without risk factor. For caesarean section, oxytocin 5 unit slowly intravenous. Okay, if the patient is having a high risk for the development of the PPH, then we may consider ergometrin plus oxytocin. Okay, ergometrin plus oxytocin, that is symptometrin, provided there is no contraindication to ergometrin like hypertension. Okay, so this and even the tranexamic acid can also be used at the time of caesarean section. Okay, so these are the options they can ask you. Then PPH management. How will you identify? Visual blood loss estimation is inaccurate. Assess with clinical signs. Communication and team activation. Explain events to woman and partner from the outset. Minor PPH is around 500 to 1000 ml. No shock. Alert midwife in charge. First line obstetric and anesthetic staff. So for minor PPH is around 500 to 1000 ml and there is no shock. Then second is a major PPH where there is a blood loss more than 1000 ml, or there is an ongoing bleeding, or the patient is in shock. Okay, what you need to do? Summon senior multidisciplinary team. Here there is a role of multidisciplinary team. Okay, here you need to keep the people informed. Okay, alert midwife in charge, first line obstetric and anesthetic staff. Once there is a minor PPH, in major PPH you need to summon the senior multidisciplinary team. Okay, and then coming to the resuscitation for minor PPH, a single large bore IV cannula you can use 14 gauge. Then blood test you need to send CBC, coagulation profile, fibrinogen. Okay, you need to monitor vitals every 15 minutes and give warm crystalloid infusion. For major postpartum hemorrhage, airway, breathing, circulation we need to assess. give flat position, keep the patient warm. Rapid warm fluids, approximately 3.5, 2 liters of warm saline and 1.5 liters of colloid if the blood is not available. Okay, early blood transfusion is needed. Avoid starch, that is hydroxyethyl starch. Just a moment. So avoid starch, then give blood transfusion. Decision based on clinical plus hematological assessment. Use O Rh negative, K negative blood until the group specific blood is available. So what blood is used? O negative, Rh negative, and K negative. Okay, O Rh negative and K negative blood is used till the group specific blood is available. That is in emergency. Maintain stock in all delivery units and consider cell salvage in caesarean or vaginal PPH. Okay. Now, what is the role of blood components? You can use fresh frozen plasma after 4 packed cells or early if suspected coagulopathy. Then fibrinogen, you need to maintain more than 2 gram per liter, replace with cryoprecipitate, and platelet transfusion you need to give once the platelet falls below 75,000. Okay, so the questions are generally asked regarding the blood and blood components in PPH. Okay, which blood component is required? They'll give you the scenario, they'll give you that these are the vital parameters and these are the values. Okay, and what will be the blood component of choice? They may give you serum fibrinogen value which is less than 2 gram, and will ask you what will you use as a blood component. Then cryoprecipitate will be your answer. Okay, and the platelets are 70,000. In that particular case, platelet will be required. Okay, but if both are there and if you have to choose one, like this is less than 1 and this is, they have given 70,000, then also better to select cryoprecipitate, because fibrinogen you need to maintain more than 2. Okay, if only one option is there. If both are there, that cryoprecipitate plus platelet, you will choose both. Okay, then drug, tranexamic acid is recommended in postpartum hemorrhage. Recommended factor 7 not for routine use except in trials. Monitoring in major PPH. Full blood, cross match, CBC, coagulation, renal profile, liver, all these you need to monitor. MRCOG chart you need to do. And then what is the role of anesthetist? Maintain hemodynamic stability, choose the appropriate anesthesia. So that is what is the role of the anesthetist. Generally in part 3 in labor ward scenario, they ask, they give that you are the team leader, you have anesthetist with you, so you need to delegate the work appropriately. Okay, then arresting the bleeding. What are the ways? Pharmacological measure, mechanical measure, and surgical measures. So these are the measures for the management of the postpartum hemorrhage. If uterine atony, we use uterotonics sequentially and mechanical pressure. If drugs fail, we go for surgical intervention. Then first line surgical intervention is a balloon tamponade. Second line, what we have a conservative surgical techniques. Then we have hysterectomy. The decision will be taken if it is early, if it is a case of placenta creta or uterine rupture, etc. Then if it is a secondary PPH, we'll send the swabs for microbiology, antibiotics for suspected endometritis, ultrasound to assess for written products, and USG surgical evacuation by experienced clinician. Okay, so that is how the secondary PPH is managed. Now, risk management and training. Again, this is not for the second part 2, so we will skip this. Coming to the, now we have finished with the executive summary. So here actually the details of the guideline begin. So primary postpartum hemorrhage. So most common obstetric major obstetric hemorrhage is a primary postpartum hemorrhage. Then we have minor and the major. Minor is more than 500 but around up to 1000. Major is more than 1000 ml, which is again divided into moderate and severe. Moderate is 1000 to 2000 ml and severe is more than 2000 ml. Okay, In women less than 60 kg, smaller losses may be significant, and these guidelines or these definitions are applicable mainly for the primary postpartum hemorrhage, not for the secondary postpartum hemorrhage. Okay, so these are quantitative definitions. So in secondary PPH, it is an abnormal excessive bleeding from 24 hours to 12 weeks postpartum. Remember, it is 12 weeks postpartum. Normally, we are generally calculate up to 6 weeks, but here secondary postpartum hemorrhage by definition from 24 week onwards till 12 weeks on. Up to 12 weeks. Okay, women with bleeding disorders or anticoagulants are at higher risk. Guidance on this is available. Okay, then prediction and prevention of PPH risk factors. Risk factors may be antenatal or intrapartum. Care plans should be updated as they increase. Women with known risk factors should deliver in a hospital with on-site blood bank. Most cases occur without identifying risk factors, and these risk factors are there are 4 T's, that is tone, trauma, tissue, thrombin. Okay, and most common is a uterine atony. Okay, so these are the 4 factors. Okay, let's see in this particular table regarding these high risk factors. So what are the high risk factors? One is a multiple pregnancy. The odds ratio is this. Okay, then previous PPH, here tone factor is there, preeclampsia, here thrombin is the responsible factor, then fetal macrosomia, again tone, failure to progress, again tone. Okay, but what you see is the odds ratio among all these high risk factors. Here high is for this 3.3. then in intrapartum factors, these are antenatal factors. Then intrapartum factors, we have prolonged third stage, then retained placenta, placenta accreta, episiotomy, then perineal laceration, and general anesthesia. So the highest in intrapartum factors, odds ratio is seen 7.8, 3.5 to 7.8 for retained placenta. And for antenatal factors, it is a multiple pregnancy. Odds ratio is around 4.7. Okay, so if these same options are given, all options, you will feel that all options are causing postpartum hemorrhage. Then you need to take into account the odds ratio and decide which one is the best one. Okay, and the lowest is a perineal laceration, responsible for postpartum hemorrhage. Okay, now minimizing the risk. One, correct antenatal anemia, that we have already seen in the executive summary. If you need to treat anemia if the HB is less than 11 in the first contact or 10.5 at 28 weeks of gestation. You need to treat with iron. Consider parental iron if oral iron is ineffective. HB less than 9 gram is linked to the greater blood loss. Okay, reducing the blood loss at delivery. Okay. Uterine massage is not beneficial. Then prophylactic uterotonics are indicated. Vaginal delivery for a low risk woman, 10 units of oxytocin intramuscularly is the uterotonic of choice. For caesarean section, 5 units slow IV. This also we have seen. Okay, reducing the blood loss further, we go ahead. High risk women, you may consider symptometrin, that is ergometrin plus oxytocin. Okay, and during caesarean section, tranexamic acid can also be used. Then active management of reduces the PPH risk versus expectant management. Early cord clamping less than 1 minute is not recommended unless there are concerns for the cord and baby. Oxytocin is preferred over the misoprostol or prostaglandin for routine prophylaxis. Okay, so the first drug preferred is oxytocin. Then what is the role of carbetocin? Carbetocin reduces the need for additional uterotonics in elective caesarean section, but no PPH risk difference from the oxytocin. So it reduces the need for additional uterotonics. Okay, in elective caesarean section, but no PPH risk difference from the oxytocin. Then tranexamic acid reduces the significant blood loss in caesarean, but not in vaginal delivery. Okay. So here the same vaginal delivery, no risk factor, 10 units of oxytocin. Caesarean section, oxytocin, slow IV, 5 international units over a period of 1 minute. High risk patient, but does not have hypertension, you can go for symptometrin, that is 500 micrograms of ergometrin plus 5 units of, remember this, otherwise they can confuse you in various strength. Okay, and 5 units of oxytocin. Then tranexamic acid at caesarean section. Carbetocin you can use during elective caesarean section, 100 microgram over a period of 1 minute, and misoprostol can be used as an alternative where oxytocin is not available, but it is less effective than the oxytocin. What is recommended is the active management of the third stage of the labor. Early cord clamping is not recommended, and uterine massage is not recommended. So they are not helpful in prevention. Okay. Then PPH severity assessment, visual estimation. This all we have seen. Okay. What happens, there is a clinical signs of hypovolemia in assessment, but in pregnancy, pregnancy will mask the early signs due to increased blood volume. Because of the physiological response in pregnancy, normal pulse and blood pressure will be there till the patient loses up to 1000 ml of blood loss. Tachycardia, tachypnea, mild systolic blood pressure, these are seen when the blood loss is around 1000 to 1500. So hemodynamic parameters will start deteriorating, and systolic blood pressure will be less than 80 millimeters of mercury, and there will be worsening tachycardia, tachypnea, altered mental state when there is a blood loss more than 1500. This question has been asked. They have given only the clinical parameters of the patient, and they have asked you what is the approximate blood loss. Okay, so if there is no altered mental status, there is no tachypnea, in that particular case, remember, only if these features are there, then it is 1000 to 1500. If you have got a altered mental status and tachypnea, the systolic BP is less than 80, then the blood loss is more than 1500. Okay, so even if the only clinical scenario is there, you should be able to answer. Another is a shock index. Okay, that is heart rate divided by systolic blood pressure. Okay, so the same thing, only up to 1000 you may have pulse BP normal. Between 1000 to 1500 there will be tachycardia, tachypnea, etc. But the blood pressure will be slightly reduced. But more than 1500 there will be systolic of less than 80, and there will be further tachycardia, tachypnea along with the altered mental status. Shock index more than 1 will suggest hemodynamic compromise and a higher risk of adverse outcome. Okay. Then communication and multidisciplinary team. If it is a minor PPH, 500 to 1000 ml, there is no shock. Midwife in charge, who will look into it? Whom to inform? Midwife in charge, first line obstetric and anesthetic staff, and extra actions, begin minor PPH protocol. Major PPH, more than 1000 ml, the patient is still bleeding or there is a shock, you need to call the senior members. Okay. Then severe or major PPH more than 1000, the consultant obstetrician must attend in person. Okay, especially this is indicated in part 3 when you have been given a scenario, the consultant is away, he will take 20 minutes to reach, the patient has lost this much of blood, I will call the consultant to visit and see the patient. By that time, I'll do this is how you need to answer. Then resuscitation. Okay, for minor PPH where there is a blood loss more than 500 but up to 1000, single cannula 14 gauge is sufficient. Urgent venipuncture, send group and screen, then full blood count, coagulation screen, etc. you need to send. Monitor every 15 minutes, and you need to assess airway, breathing, circulation, fluid, etc. Okay. So fluid volumes, this is in major PPH. Fluid volumes up to 2 liters of warm isotonic crystalloid you can give. Okay. Then fresh frozen plasma, 12 to 15 ml per kg if PT and APTT are prolonged, and blood test give after 4 units of RBC. Okay, so the dose for the FFP is 12 to 15 ml per kg if PT and APTT are prolonged. Okay. Then platelets, one pull if going ongoing bleeding and platelets are less than 75,000, you give platelet, and cryoprecipitate you will give 2 pulls if the fibrinogen is less than 2 gram per liter. Okay, so you need to remember these particular values because they are frequently asked. Okay, and you need to remember the dose also. Okay, per kg. Again, there are a few clues here. We'll see in the subsequent slide. Okay. So resuscitation PPH, you will give high flow oxygen. Even if saturation is normal, then you need to give airway compromise, then urgent anesthetic help. This you will do. For major PPH, you need to have 2 14 gauge cannula. You need to send the sample and cross match 4 units of blood. Okay. Now, what are the targets you need to maintain? You need to maintain HB more than 8. platelet should be more than 50,000, then PT should be less than 1.5 of normal, APTT should also be less than 1.5 of the normal, and fibrinogen should be 2 gram. You need to maintain the blood parameters in this particular range. So that is what is our target of giving all these blood and blood components. Okay, so HB should be more than 8, platelet should be maintained above 50,000, and when the patient is bleeding, once the platelet come below 75,000, you will start giving the platelets. Okay, and you need to maintain above 50,000. Okay, platelet PT and APTT should be less than 1.5 times of the normal. Then fluid replacement, restore blood volume and oxygen carrying capacity. Assume blood loss is underestimated and don't delay for lab if clinical need is clear. Okay, so isotonic warm isotonic saline up to 2 liter you need to give as early as possible. Okay, then after that you can give warm colloid up to 1.5 liter if blood is not yet available. Okay, so if the blood is not available, then you will give additional 1.5 liter, and the total 3.5 liter what we have seen in the previous slide. So you start with 2 liters of warm isotonic crystalloid. If the blood becomes available, you will go directly for the blood, but if the blood is not available, then you will go for warm colloid. Okay, then what is recommended? Isotonic crystalloids are recommended. WHO recommends as the first choice, and colloids, no proven survival benefit, and Hestarch is known to increase the mortality. Okay, regarding the blood transfusion, there is no absolute cutoff, but if the HB is less than 6, you have to give blood, and it is rarely required if the HB is more than 10. Okay, acute hemorrhage may present with normal hemoglobin, rely on clinical picture. Okay, so in immediate, what type of blood you will ask? Okay, immediate major obstetric emergency, then you need to have O negative and K negative. If the patient is known to have a clinically significant antibody, then you will give blood which does not have antigen and it is negative for that antibody. Okay, or the blood should be negative for that antigen corresponding to that antibody which the patient is having. Okay, then Rh negative women give only Rh negative blood. K negative policy, K negative unless woman is a K positive. Then antenatal elective transfusion, CMV negative and leukocyte depleted. So if it is an elective transfusion, then CMV negative and leukocyte depleted blood. But in emergency, O negative, K negative. Okay, if she is positive for some antibody, that should also be negative. Antigen should be negative. In emergency, standard leukocyte depleted blood is used. Then selection of the red cell units, we have just seen this O negative and Rh negative. This we have just seen. Intraoperative cell salvage used in cardiac, orthopedic, and vascular surgery. It reduces the BT rate of around 30% and 21% absolute transfusion reduction rate is seen. Okay. Management of hemostatic impairment in postpartum hemorrhage. Principle is to correct hemostatic abnormalities only during bleeding and not in stable patient. Okay, when your patient is bleeding and having postpartum hemorrhage, you need to correct the hemostatic abnormalities only during bleeding, not in stable patient. Assessment methods, clinical observation, lab test, PT, APTT, class fibrinogen, platelet count, etc., etc. Point of care system. These are the coagulopathies will evolve quickly, so you need to repeat the test. These are the tests which are indicated. Then FFP. This can be asked. If no hemostatic test results are available and the bleeding is continuing, okay, if PT, APTT values are not available, there is a bleeding which is continuing, then after 4 units of Paxil, you will give the FFP at a rate of 12 to 15 ml per kg until the results become available. Okay, so check the scenario what is given to you, how much the patient has bled, how much the patient has received, whether PT, APTT values are given to you or not. If the PT, APTT values are not available, if the patient has lost the blood and you have given the 4 units of packed red blood cells, then you will give FFP at a rate of 12 to 15 ml per kg until the results are available. And you may give early if there is an abruption, amniotic fluid, embolism, and delayed PPH detection. If the PT APTT values are available, if PT and APTT are more than 1.5 and the patient is bleeding, then larger volume of FFP will be required. So that will be more than 15 ml per kg. Okay, so here there is a difference in the dose. Okay, if the APTT and PT values are deranged, you will give more than 15 ml per kg. Okay, you need to order early because there is a thawing time. Okay, then what are the risks? The risk can be transfusion associated circulatory overload, that is TACO, and TRALI, that is transfusion related acute lung injury. Okay, if PPH is stopped, no FFPs are required. If PT and APTT are normal, bleeding continues. Okay, no FFPs, repeat testing if bleeding persists. If massive bleeding more than 8 pack RBCs and no coagulation results, give 2 pools of cryoprecipitate and 1 pool of platelet. In cases of massive bleeding, if you have given 8 units of pack red blood cell and no coagulation results, in that particular case, what is required? 2 pools of cryoprecipitate and 1 pool of platelet. Okay, so this also we have seen 12 to 15 ml. When will you give? Then more than 15 ml, when will you give? When your PT APTT are more than 1.5. If your PT APTTs are normal, no FFPs are required. If you have given more than 8 RBCs and no coagulation studies are available, then you will give 2 pools of cryoprecipitate plus 1 pool of platelet. Okay, so these are the things which you will remember. Then what about the fibrinogen? If the fibrinogen is dropping, okay, then you need to give. So let us see, the target level is more than 2 grams per liter. Preferred replacement for fibrinogen is by cryoprecipitate. Okay, then what is the effect of cryoprecipitate? 2 pools will increase the fibrinogen by around 1 gram per liter. Okay, so that is what is the role of cryoprecipitate. Okay, when you have the serum fibrinogen value given less than 2 gram percent, you will give cryoprecipitate. Okay, then platelet transfusion. Transfuse when the platelets will drop below 75,000 and your target will be to keep the platelet above 50,000. Okay, so this is the indication to start, and target to maintain always above 50,000. Okay, then management of the blood component, when to give FFP, this we have seen. There is a little repetition of the slide just in a tabular format I have made, so I won't repeat. This also we have seen. Fibrinogen replacement we have seen. 2 pools of cryoprecipitate will increase by 1 gram per liter. Okay. Platelet transfusion, this also we have seen. Okay, then factor 7A in life-threatening PPH. Okay, do not delay definitive procedures. So factor 7A is rarely required, only in life-threatening PPH, but most of the questions they ask about FFP, fibrinogen, platelets, and cryoprecipitate. Okay, so these are the questions which are frequently asked. Recombinant factor 7A, what they are saying, considering life-threatening PPH, should not delay or replace life-saving interventions such as uterine artery embolization, surgery, etc., etc. Then how do you monitor and investigations in major PPH more than 1000 ml? Okay, this also we have seen, and monitoring you have to do this post stabilization. Once the bleeding is controlled, consider the patient shift to the ITU or HDU on delivery suit depending upon the severity. Okay, role of anesthetist not for examination, so we'll skip these slides. Yes, now coming to the ways of arresting: pharmacological, mechanical, and surgical methods. Okay, so initially what you can do, rub the uterine fundus. This is in management of PPH, not in the prophylaxis. Okay, rub the fundus, empty the bladder, and go for sequential pharmacological steps. So this protocol is going to be important. They'll give you the scenario of atonic PPH, and they will ask you what is going to be the first step. Then first step, it may be rub the uterine fundus. Okay, or if it is related to the blood components, then you will select the appropriate. Or if they may say that you have started with the medications, in which they'll give you that oxytocin 5 unit is given, then what should be the next? Then look for, is there any contraindication to the ergometry. If there is no contraindication to ergometry, then you have to use ergometry. Okay, once you have given 5 units of oxytocin slowly. After ergometry is the oxytocin infusion, 40 units in 500 ml at the rate of 125 ml per hour. Okay, this is the rate. After that comes the carboprost. Okay, 250 microgram intramuscularly every 15 minutes, up to 8 doses you can give. Okay, or maximum 2 milligram. Okay, it is contraindicated in asthma. And after that is a misoprostol 800 sublingual. Okay, slower onset, around 1 to 2.5, less effective. Okay, and if there is no improvement after 3 doses of carboprost, you need to shift the patient for examination under anesthesia and laparotomy or hysterectomy. Okay, so this protocol you should remember, because there will be question on this or on the blood component. That is why I have gone into the details of the blood component. Okay, then first early surgery. If drugs fail, then we will go for surgery. The first line is a uterine balloon tamponade for attorney. You can use Bakri balloon or this thing. Success rate is 90%. Then second line conservative surgery are hemostatic sutures like B-Lynch or modified B-Lynch, etc., etc. Details are not expected from you. You just need to select the choice. Okay, success rate is around 75%. Then after that, you go for stepwise vascular uterine devascularization. That is sequential ligation of uterine and ovarian arteries. High success rate in case series. Fertility remains unaffected. And what you do? Go for one uterine artery ligation, then both uterine artery ligation, low uterine arteries ligation, then one ovarian artery, and then both ovarian arteries ligation. That is what you go sequentially. After that is the internal iliac ligation. Okay, then comes the interventional radiology if the facilities are available. Selective arterial embolization, success rate is 86%. After that is the role of hysterectomy. You go for subtotal hysterectomy unless lower segment of the cervical segment is also involved in causing postpartum hemorrhage. Okay, so that is what is the role of surgical management of the postpartum hemorrhage. Okay, now coming to the secondary postpartum hemorrhage, you need to check the hemodynamic status, quantity of the blood loss, address woman's concern, endometritis, retained products of conception, subinvolution of the placental site. These are the causes. Then what you will say in the vaginal swab for microbiology and pelvic ultrasound to assess for RPOs. Okay, so the investigation of choice, these will be the investigations of choice in secondary PPH. Antibiotics will be clindamycin plus gentamicin, and you will give appropriate uterotonics also, and you need to go for evacuation of the RPOC under appropriate anesthesia. Okay, you may consider under the ultrasound guidance also. Okay, the risk of uterine perforation is around 1.5%, and there is a risk of Asherman syndrome also. Okay, so this is what is about the secondary postpartum hemorrhage. Okay, risk management again not expected for part 2, so I'll skip this slide. Debriefing, this is a part expected in part 3. So that finishes the topic of postpartum hemorrhage. Thank you. Dr. Simchana and Dr. Amrita, you understood the important points. I have not gone into certain details.
Sir.
Okay, I have mainly focused on the areas where the questions are asked. Okay.
Yes, sir.
Because we know these particular guidelines in detail. Okay. So
Yes,
you need to focus on those particular guidelines. The next is we start with our next guideline, that is preterm labor and birth. It is a nice guideline published in November 2015. Okay, this is a short guideline. So what information support for planned preterm birth or treatment for preterm labor we need to provide? We need to provide the woman with information regarding the cervical chances and the possible outcomes. The neonatal care details we need to discuss. Immediate problems after the preterm birth. Possible long-term consequences. Ongoing discussion and wishes about baby's resuscitation. Opportunity to treat. They can visit the neonatal unit, or they can speak to the neonatologist and pediatrician. This is what the NICE says, that whenever you are dealing or delivering the preterm, we need to carry out these things. Then most important, the frequently questions are asked on this particular slide. What is the role of prophylactic vaginal progesterone and prophylactic cervical encirclement? When to do? And very confusing. And always, every exam, always there is a question here. Okay. So offer choice of either of the vaginal progesterone or prophylactic cervical cerclage to women who are having both criteria. Now, what are the criteria? If there is a history of spontaneous preterm or mid-trimester loss between 16 to 34. So, if there is a spontaneous preterm or second trimester loss between 16 to 34 and transvaginal ultrasound which is done between 16 to 24 is suggestive of cervical length less than 25, in that particular case, you can give the choice of these two. Okay. Then offer prophylactic vaginal progesterone if there is no history of spontaneous preterm birth or the mid-trimester loss, but the ultrasound is showing cervical length. So previously either she has not delivered or full term delivered, but currently cervical length is less than 25. Then what will you offer? You will offer vaginal progesterone only. Most of the time we are tending, selecting this cervical encirclement. What does the NICE guidelines say? If there is no history of spontaneous preterm birth or mid-trimester loss, and the ultrasound between these 16 to 24 is showing 25 millimeter, less than 25 millimeter, then we will offer vaginal progesterone. But if there is a history of spontaneous preterm or mid-trimester, we can offer choice of both. Okay, and we will offer prophylactic cervical encirclement if this cervical length is less than 25 millimeter and there is a previous PPROM. Okay, if there is a previous preterm rupture of membrane, in that particular case, definitely cervical encirclement is indicated, and if there is a cervical trauma. Okay, so this is what the guideline says. If there is a previous PPROM and or there is a cervical trauma and there is a cervical length reduced, then you go for prophylactic cervical encirclement. Okay.
Sorry, sir. I have a question, sir.
Yeah. Yes.
Supposing the patient in question just had a previous spontaneous miscarriage within the second trimester, or she has had a previous history of preterm birth between 16 to 34 weeks only.
Yeah.
And the cervical is greater than 25 centimeters. What option do we have?
See, if it is a 25, then this particular thing is not there. If it is less than 25, then we can offer her either vaginal progesterone or prophylactic cervical encirclement. Now you say that there is a preterm birth between 16 to 34. Is that correct? There is a history
Yes,
of
sir.
Yeah, and the cervical length is exact 25 millimeter.
No, cervical length is greater than 25.
Greater than 25. Greater than 25. How many spontaneous preterm birth? No, if there is a, see, if there is a previous preterm, but the cervical length is good, then there is no indication for cervical encirclement. There is no indication for the prophylactic vaginal progesterone also, because cervical, because we are screening them on cervical by cervical length. That is our parameter, and we are treating with respect to their history. You got it? So the screening is with respect to cervical length. So I don't think any of the option will be required for them. Okay, because cervical length is good. So routine care. Okay. And obviously serial cervical length monitoring will be there for those patients. Okay, if that option is there, we can select that serial cervical, because we need to monitor the cervical length between 16 to 24 weeks and then decide. Okay, again, single cervical length may not be sufficient. Okay. So this is, I think, wrong table has posted here. We'll not go into the details. So diagnosing preterm pre-labor rupture of membrane, PPROM. Okay, if symptoms are suggestive of PPROM, the first examination is a speculum examination. Remember, this is the question which is asked. What is the next step? It is a simple speculum examination. If you see the pooling of the amniotic fluid, diagnose that this is a PPROM and offer care as per the guideline which we are going to discuss. If there is no pooling, Then what you have to do, either IGF BP1 test, okay, insulin like growth factor binding proteins, or PALM G1 test on the vaginal fluid. Okay, so they will give you the scenario and they will ask you the next step. If the first step will be the speculum examination. On speculum examination, if you see the pooling, then definitely it is a PPROM. If there is no pooling, then we will carry out test on vaginal fluid, either IGF-BP1 or PALM G1. Okay. If the test is positive, do not rely on the test alone. Consider history, condition, and gestation, and she will be either considered as a PPROM and will be given care, or she may be evaluated later. If the test is negative and no fluid, no antibiotics are required. Do not use nitrazine test as well. So this option don't select at all in the examination. Okay, and no diagnostic test if the labor is established. If she is already in labor, then no need of any diagnostic test. Please remember these 2-3 things when to do what. The first is the speculum examination. Look for the pooling. If there is a pooling, there is a PPROM, then offer care. If there is no pooling, go for either IGF BP1 or the PALM G1 test. Okay. Then antenatal prophylactic antibiotics for confirmed PPROM. The antibiotic of choice is a erythromycin 250 mg 4 times a day for maximum 10 days or until labor. If it is intolerant or contraindicated, consider oral penicillin. Do not use coamoxiclav for prophylaxis. Okay. And identifying infection in PPROM, use combined assessment. So when the case is a case of premature rupture of membrane, preterm premature rupture of membrane, you are kept her on expectant management, then you need to monitor for development of the chorioamnionitis. That is not a single parameter you will look into it. They always say combine assessment. It is a clinical assessment plus lab parameters such as CRP, WBCs, and fetal heart rate, that is CTG, you need to monitor. Do not rely on any one test alone. So single test is not a diagnostic. If more than one test is, then you definitely think about the chorioamnionitis. If the results conflict, continue observation and repeat the test. Then what about the rescue circulars? Do not offer if there are signs of infection, if there is active bleeding, or if there is a uterine contraction. Then when to do rescue circular? It is indicated between 16 to 27.6 weeks. This is one of the things which is asked either SBA, or they may ask you in EFQ also. They'll give you scenario and will ask you what is indicated. So if it is a case between 16 to 20.56, the option may be rescue circular. Dilated cervix with exposed and unruptured membranes. It has got a higher benefit at earlier gestation. Discuss with consultant obstetrician and pediatrician. Counsel women and family, and risk of procedure you need to discuss. It delays the birth, improves the cervical by around 34 days. So approximately 4 to 5 weeks, it will extend the prolong the pregnancy. Okay. Provided the cervix is dilated, the membranes are exposed, but there is no rupture of the membrane. You may think about this. Okay. Then diagnosing the preterm labor with intact membranes. You need to counsel the lady, clinical assessment, and diagnostic test. Okay. Here comes the role of diagnostic test as a fetal fibronectin. If in PPROM, what we have seen on vaginal fluid, IGF-BP1 or PALM G1. Okay, here you have fetal fibronectin test in preterm labor. Okay, if it is positive more than 50 nanogram per liter, then treat as a diagnosed preterm labor. If she is more than 30 weeks and no cervical length or fibronectin test is done, treat as a diagnosed preterm labor. Okay. Then do not combine cervical length plus fibronectin testing for diagnosis. So cervical length plus fibronectin is not to be combined. Okay. Ultrasound, you do cervical length by trained professional. Okay. So counseling, clinical assessment, diagnostic test, fetal fibronectin more than 50 nanogram per ml, we will treat as a preterm labor. Okay. If she is more than 30 weeks and no cervical length or fibronectin test is available, then we will treat her as a case of preterm labor. Okay. Tocolysis, we'll decide based on the diagnosis whether it is suspected or confirmed. We'll look into the contraindications, gestational age, steroid benefit, etc., etc. The nifedipine is the drug of choice. Okay, we will consider between 24 to 25 weeks, 25.6 weeks for suspected preterm labor or intact membranes. We will offer nifedipine between 26 to 33.6 weeks for suspected or diagnosed preterm labor with intact membranes. If contraindicated, use oxytocin receptor antagonist. Okay, so nifedipine is the drug of choice. If contraindicated, we can use oxytocin, that is atosiban. Okay, and it is to be considered between 10, because these are the early periods where the viability is not very sure. So we can consider, discuss always a shared decision making, but we need to offer between 26 to 33.6 weeks of gestation. Okay, then what is the role of maternal corticosteroids? Again, discuss use between 23 to 23.6. Okay, on individualized basis. These are the periods of early gestation. Even this is early gestation, but up to 24 weeks viability is not very sure, so discuss the use. Okay, then between 24 to 25.6, consider the use. Between 26 to 33.6, offer maternal corticosteroids. So the corticosteroids are offered between 26 and 33.6 weeks of gestation. And again, after 34 to 35.6, you can consider the use, but they are recommended or offered between 26 to 33.6. Before that, always consider before and after. Okay, magnesium sulfate, you have to offer between 24 to 29.6 weeks. These are the different gestational ages which you need to remember. Between 24 to 29.6 weeks of gestation, if it is a established preterm labor or planned preterm birth, which is where the delivery is expected in next 24 hours, and you will consider after 30 weeks up to 34, that is 33.6 weeks. Okay, same, and 4 gram over a period of 15 minutes, and then 1 gram per hour. That is what is the dose for magnesium sulfate. So that finishes this short guideline, nice guideline. Okay, on preterm labor. Here the questions will be on what you are going to offer, then IJF, BP, speculum examination, and fetal fibronectin. So these are the questions which can be asked. Then we start with the next topic, care of women presenting with suspected preterm premature pre-labor rupture of membranes from 24 weeks of gestation. This is a green top guideline number 73, published in June 2019. Okay, so what we have seen before was also PPROM from the NICE guideline. Here it is a green top guideline. Okay, same thing is they have discussed sterile speculum examination. If there is no pooling, we'll go for IJBP1 or PALM-G1. Antibiotic of choice, erythromycin 10 days or until labor. Then corticosteroids 24 to 33.6. Here there is a little, they have mentioned 26 to 33.6. We'll see those in subsequent slide. Again, consider between 35 to up to 35.6. Okay, choriamnitis, it is a combination of clinical assessment plus test. Okay, so this all we have seen. And continue pregnancy until 37 weeks if there are no contraindication. Individualized timing based on patient preference. Okay, magnesium sulfate, gestational age between 24 to 29.6. This also we have just seen. Okay, so this is going to be the repetition of the previous things. Okay, incidence of PPROM is, it is affecting 3% of all pregnancies and constituting around 30 to 40% of the preterm births. So this figure you can remember. Preterm labor, this PPROM overall incidence is 3%, and it is contributing to 30 to 40% of preterm births. Okay, rest of the things are not very important. This again a repetition, IJF BP1 or PALM-G1 on the vaginal fluid if there is no pooling after the speculum examination. Okay, nitrazine test is not indicated. USG ultrasound oligohydramnios may support the diagnosis. If PPROM not confirmed, resume routine antenatal care. Okay. So what do you do? Assessment for infection, we monitor clinically. Then CBC, that is white cell count we do. CRP we do. Then symptoms we will watch, inpatient care and outpatient. If the patient wants to go home, she can go home provided there is no chorioamnionitis, but you need to call her weekly or bi-weekly for review. Okay, just hold on. Stop. So neurologist involvement, inform early, and antenatal discussion is very, very important. Antibiotic management in PPROM, first line is erythromycin 250 milligram 4 times a day for 10 days. Okay, that is what is the preferred antibiotic. And avoid co-amoxiclav because it causes neonatal necrotizing enterocolitis. So this is what is important on this particular slide. Yes, maternal corticosteroids as per the GTG 24 to 25.6. Here they have mentioned offer. 26 to 33.6 they have mentioned offer, and 33 to 35.6 consider. But if we have seen the nice mentions between 26 to 33.6 offer, and before that it is consider. Okay, what does it do? It reduces the RDH, it reduces IVH, decreases mechanical ventilation. Between 34 to 35.6, it is individualized decision due to high number needed to treat and possible side effects. Okay, so after 34 weeks, always consider. Okay, and there is a 1++ evidence for 26 to 33.6. Okay, then magnesium sulfate we have seen when to offer in established labor from 24 to 29.6. Again, 1++ level incidence. Okay. Then consider between 30 to 33.6. Tocolysis we have seen in PPROM, it is not recommended. While you can use it in preterm labor, but in PPROM, it is not recommended. Okay. So home monitoring can be advised. Okay. And you need to call the patient for follow-up. And these are the risk factors which require hospital care. That is PPROM before 26 weeks of gestation, non-cephalic presentation, oligohydramnios. Okay. Amnioinfusion does not have role. Okay, here that is the only thing. PPROM increases the risk of post-traumatic stress disorder by 14% antenatally, 17% at 6 weeks postnatal, versus 2 to 3% in uncomplicated pregnancies. Okay, so there is an association with the mental health. Most of the time they can ask you about the mental health also, and the PPROM and mental health relation is PTSD, that is post-traumatic stress disorder, is seen in 14% of cases antenatally and 17% at 6 weeks in PPROM cases, versus 2 to 3% in uncomplicated pregnancies. So emotional support should be provided both during pregnancy and after birth. Okay. Then birth timing and delivery in PPROM. So women with PPROM after 24 weeks and no contraindication should be offered expectant management until 37 weeks. Timing of birth should be individualized. Okay. And early delivery, if there is a respiratory distress, early delivery, what are the neonatal complications? RDS, chances of caesarean section are high, neonatal death, need for ventilation. So these are the things which can happen. Care in subsequent pregnancy following PPROM. Women with history of PPROM should be managed by an obstetrician with interest in preterm birth. Ideally, care should be dedicated in a preterm labor clinic. Risk of recurrent PPROM is significantly increased. Remember the odds, it is high, 8.7 for white and 7.2 for African American women. Okay, so you need to advise the modifiable factors like a smoking, respiratory. You need to address these particular factors. Okay, and consider supportive measures. So these are the things which you can do. And serial transvaginal cervical length scans. Okay, so this is what is the summary. Erythromycin for 10 days, the magnesium sulfate between 24 to 29.6. Please remember these gestation because we get confused while we are answering. Okay, antenatal corticosteroids offer between 26 to 33.6. Okay, then so most of the points we have covered. Okay, so that finishes this particular guideline also. Thank you. Welcome all to the class. So today's guideline is a postnatal care, nice guideline. So we begin with our tagline, Master MRCOG with concept-oriented clarity. So this is the first slide, which is going to be very, very important from examination point of view. They ask you various rates or various health indicators. The most important is the maternal mortality per 1 lakh live births. You need to remember the numerator as well as denominator also, because they confuse with various figures. Okay, so mortality is always per 1 lakh live births. So white women has got maternal mortality of around 8 per 1 lakh live births. Black women is 4 times higher. So the question can be either 4 times higher, or they may say ask you 34 per 1 lakh. Okay, then mixed ethnicity 3 times higher. Okay, that is 25. And Asian women, not inclusive of Chinese, around 15, that is 2 times higher. So remember the baseline 8, then black have got a 4 times, mixed ethnicity has got a 3 times, Asian women have 2 times, and accordingly the figures are 8, 15, 25 and 34. Okay, so these figures you need to remember, because these are numericals, and most of the candidates get confused for numericals in the examination. But these are the questions which are frequently asked. The neonatal mortality per 10,000 live births. Okay, so this is calculated per 10,000 live births. For white babies, it is 17 per 10,000. For black and Asian babies, it is 25, almost 50% higher. Okay, then if the women are deprived of health facilities and all, if they are from this deprived category, then what is the maternal mortality? Least deprived will have a 6 per 1 lakh, and most deprived will have a 15 per 1 lakh. Okay, that is 2.5 times higher. Then deprivation impact on neonatal mortality, least deprived are around 12. Okay, and most deprived are around 22. Okay, so these are the figures out of which they are asking about this. Okay, most of the time the question is on the maternal mortality in black women, or maternal mortality in mixed ethnicity, or for the white women. You need to, rest of the guidelines I'll just read it. Okay, nothing specific in this particular guideline. You need to involve the partner, then you need to see the parental responsibility, you need to share the information, and your information should be clear, individualized, sensitive, etc. Offer thought throughout care. Aim should be supporting and shared decision making. It should be supportive and respectful, and your guidance should always be evidence based and consistent. Okay, then additional support as per NICE guideline on pregnancy and complex social factors. Women needing extra support. So which women need extra support? The patients with substance misuse, recent migrants, asylum seekers, refugees, language barriers, young women less than 20 years, and women experiencing domestic abuse. Remember, these are the women, and you may get some questions that the lady is asylum seeker or refugee and all, and their mental health also, their domestic abuse is also very common, domestic violence is also very common. So your question may involve those answers also, and these are the women which need extra support. So when you see these particular things in your scenario, that she has recently migrated, she is an asylum seeker, think of other social factors also apart from clinical. So before transfer to the community, there is always a transfer of care of that particular women. If the patient is delivered in the hospital, then she'll go into the community, then community midwife will take care, and health visitor is also there. So these are certain instructions. The first midwife visit is within 36 hours after transfer of care or after home birth, and face to face or usually at woman's home. Then first health visitor visit is between 7 to 14 days after transfer from the midwifery care. Okay. Then red flag symptoms, inform first midwife visit, seek urgent medical advice if there is a sudden heavy persistent vaginal. So these are the symptoms one should look for in the first visit. If there is a heavy bleeding, abdominal, pelvic or perineal pain, fever, foul smelling discharge, etc., etc. Okay, and if the woman has got specific conditions like hypertension, preeclampsia, we need to monitor, treat and advise, and give appropriate follow-up advice. Okay, then for diabetes, the advice will be as per the NICE guidelines. VT assessment is always there, and we need to manage this urinary incontinence and the pelvic organ prolapses. Then regarding the bleeding, advice to women, if there is a heavy bleeding, bleeding is increasing or passing clots, etc. Okay, assess severity, consider PPH risk factors. If there is anemia, maternal weight less than 50 kg, these are the these patients have a worsening outcome. Perineal health, you need to look into the persistent or worsening pain, increased need for analgesia, false smelling vaginal discharge, swelling, wound breakdown, etc. And one of the important note, just listen carefully, persistent or vaginal worsening pain may be linked to the depression, chronic pelvic pain, functional or psychosexual issues, and risk factors for persistent pain may be episiotomy, tear, assisted vaginal birth, wound infection, or breakdown. So when you have got this persistent pain and all, always look for the mental health issues also. Okay, this is also one of the important thing in this particular slide. Then you need to promote the breastfeeding, and you need to tell so these are actually the job of midwife, which they will be doing. Okay, lactation suppression is indicated, one as a choice, second when the it is contraindicated, or when there is a baby loss. Okay, so these are the things about the lactation suppression. If anything specific regarding the examination point of view, I will definitely go into the detail. Yes, for the babies, they can ask you what is early neonatal sepsis, what is late neonatal sepsis. So early neonatal sepsis is less than 72 hours, and late neonatal sepsis is more than 72 hours. Rest of the things, red flags for the babies and all, this is a part 3 MRCOG thing, so we will not go into the detail. Assessment and care of the baby, nothing specific here. Yes, regarding the bed sharing practice, baby should be on a firm flat mattress, face up, no sofa, chair, sleeping, etc., etc. And strongly avoid bed sharing if baby is low birth weight, parents are smokers, or has more than 2 units of alcohol, use sedating if they are using sedating medicines or recreational drugs. Okay, so these are the important advices. So only important things from this particular guideline we have discussed about various figures and the early onset sepsis and late onset sepsis. Okay, now the last guideline is perimortem caesarean section. Why, when, and how. This is a talk article, a small talk article is there. So this we will finish. So cardiac arrest in pregnancy, key points are: it is a rare event, it requires rapid management. Perimortem caesarean section if patient is more than 20 weeks, and if there is no return of circulation after 4 minutes of CPR, then we need to go ahead with perimortem caesarean section. Okay, so pregnant woman more than 20 weeks having cardiac arrest and there is no return of systemic circulation after 4 minutes of CPR, then the perimortem caesarean section is indicated. What should be the timing? Aim is to deliver within 5 minutes to improve the maternal survival and reduce neurological risk. Remember these timings, okay, because you need to read the question what you have been asked in the examination. Sometimes they give you the scenario, they will tell you that the mother had cardiac arrest, then the team has attended, the CPR is started, airway breathing circulation has been taken care, this, that, and the 4 minutes are over. Then what is the next step? Okay, then next step will be to take the decision of perimortem caesarean section because 4 minutes are over. Sometimes they can ask you the question, in cases of perimortem caesarean section, within how much time the baby should be delivered. So the baby delivery should happen within 5 minutes of starting the CPR. Okay, so remember whether what has been asked to you, whether the answer is 4 minutes or 5 minutes, that you need to read the scenario very carefully and then select the answer. Most of the the things correctly, but you need to answer with respect to the scenario. This is what I wanted to say. Okay, so where the perimortem caesarean section should be performed, it is performed at the arrest site, and you don't have to transfer the patient to theater. Equipment is minimal, clinical area should be kept, designated equipment box should be there, and postnatally you need to do the team briefing. Okay, so maternal cardiac arrest, it is a very rare event, around 1 in 12,500 pregnancies. Yes, again one of the SBA they can ask you about the causes of cardiac arrest. The causes, hemorrhage is responsible in 45% of cases. Then this AFE 13% of cases, amniotic fluid embolism, Then heart failure in 13% of cases. These are the other causes. So hemorrhage is the most important cause for this. Okay, then most obstetricians may encounter it once or never in their career. Postmortem caesarean section is a critical part of life support in arrest for pregnant women more than 20 weeks. Survival rate is around 17 to 59%, and fetal survival rate is 61 to 80%. Okay, key factor is a rapidity of postmortem caesarean section after the arrest that will determine the outcome. Okay. So perimortem caesarean section, why and when? Resuscitation is same as in non-pregnant with some modification like uterus displacement and pad placement, etc., etc. Key difference is that perform perimortem caesarean section if there is no return of systemic circulation after 4 minutes of CPR after 20 weeks of gestation. Okay, goal fetal delivery should be by 5 minutes post arrest, primarily to aid maternal resuscitation. Okay, so this is primarily for aiding the maternal resuscitation. Terminology, it is also called as resuscitative hysterotomy. Both are acceptable. Now, what is the physiology during pregnancy? The oxygen demand is increased. There is aortocaval compression that reduces the cardiac output by 60%, and uterine emptying improves. Once you do the hysterotomy or take out the baby, the uterine emptying will improve the preload. It reduces the oxygen use and enhances the CPR effectiveness because you can give the better CPR also. Okay, the evidence is mainly on the case reports. Okay, 65% maternal survival in resuscitable cases. Conclusion is 4 and 5 minute rules are physiologically sound but not strongly proven. Okay. So there are various studies. We will not go into the details of this. We'll restrict for the examination purpose whatever the information is. So airway, breathing, circulation, chest compression ratio, they sometimes they ask you 30:2 at 100 per minute. Okay, 30:2 is the ratio at which we give chest compression. Okay, then manual uterine displacement you have to do, or you have to give 15-degree tilt. Okay, this can also be asked. This much is done. The patient has got cardiac arrest. So the first what you is always a summon for the help, but this manual uterine displacement never forget, because this is very specific for pregnant women. Then early IV access above the diaphragm. And if you are getting difficulty, then consider intraosseous fluid replacement. Okay, if IV access is difficult or delayed for more than 90 seconds, you go for interosseous route. Okay, because it is rapid, reliable. Okay, direct entry into the systemic circulation. You can use proximal tibia, proximal humerus, distal tibia. These are the sites. Okay, and defibrillated pad you need to adjust, like anterior posterior position of the defib pad. Okay, normally where do we apply in non-pregnant patient? Okay, standard pad placement is one pad below the right clavicle and the other is on the left lateral chest wall in the mid axillary line. So these are the standard pad placement, that is anterolateral. Okay, but what we have to do in pregnancy is anteroposterior. Why adjustment is required in pregnancy? In late pregnancy, the breasts are enlarged and engorged. Okay, so this can make standard placement difficult. Okay, pads may not adhere well or may sit too far laterally. Okay, so that will reduce the effective energy transfer through the heart. So that is why we need to go ahead with the anteroposterior. That is, anterior pad will be on the sternum or the left parasternal area, and the posterior pad will be between the two scapulae. Okay, so this is what is the pad placement. Then decision for perimortem caesarean section, we have seen if there is no return of systemic circulation after 4 minutes of CPR after 20 weeks. Okay, then we go ahead with this. Okay, it should be performed at the site of arrest. Okay, pre-hospital means in the community only if the staff is trained, then only we can carry out. Anesthesia is not needed. Okay, sometimes they can give you various options with anesthesia, but anesthesia is not required. Okay, and if there is a return of systemic circulation, convert to GA to complete the surgery. Okay, then what are the steps? No full scrub or sterility is required. Gloves and apron are sufficient. Abdomen cleaning is optional. Don't delay the procedure. Minimal equipment. Remember, minimal, only what is required: scalpel and 2 clamps or ligature for the cord. There is a kit we will discuss. This is a perimortem caesarean section box or the kit, like eclampsia box. There is a kit. Okay. Then there is a Bladder emptying is also not required, and no GA required to start the procedure. Okay. So what we do, abdominal entry, how it is done? It is midline vertical incision. Alternatively, transfer of vertical if the operator is familiar. Okay, but vertical has got a advantage of fastest access and best exposure. If trauma is suspected, always vertical in subumbilical midline incision. Okay. Then uterine incision. What should be the uterine incision? Between 20 and 28 weeks of gestation, vertical incision, especially when the surgeon is inexperienced, it is a faster. So uterine incision may be vertical or maybe lower segment transverse incision also if it is a more than 28 weeks and experienced surgeon. Okay, incision should allow quick delivery. Okay. Then placenta can be delivered or left in situ because we have to concentrate on the resuscitation. So the resuscitation is primarily. Okay. So continue maternal resuscitation. With return of circulation, placenta often separates and naturally with the uterine tone. Be prepared for the bleeding and ensure tone is maintained. Management of with return of systemic circulation, bleeding sources, the patient may develop atonic uterus or uterine incision edges can bleed. So initial control will be with a pressure packs swab. Then you can transfer the patient to theater, give GA, and do it in a proper way. Closure, lower segment, standard closure. What we do, if you have taken the vertical incision or upper segment, then you have to carry out 3-layer closure. Okay. Then management, if there is no return on of circulation, then we will continue the CPR until the senior team decide to stop. If you need to declare the death, then secure the IV lines and tubes should be in C2. Do not remove the placenta, leave the uterus open if required. So you have to keep the situation as it is. Okay. Only thing is that you may close the abdomen with simple stitches just for the purpose of maintaining the dignity and showing it to the relative. Otherwise, you need not, because that will be going further for the postmortem. Okay. Aftercare, neonatal care, and family support are crucial. Then who is to be informed? Coroner is to be informed in cases of maternal death. Okay. Then you need to carry out debriefing. Okay. So these are the steps. Then we need to improve the care by various means. Then there is a box of perimortem caesarean section emergency kit. What are the essential things in this particular kit? Number 10 scalpel blade. Okay, it is a pre-mounted blade, curved number 10 scalpel blade, and 3 cord clamps or ligatures. This is the only essential things. So only essential things in this particular. So if you have only these 2 things are available, you need to carry out the caesarean section either in the delivery room or in the emergency department. That is what is the site for the perimortem caesarean section. The patient need not be in the theater. Okay, GA is not required to start the caesarean section. Okay. And optional things are skin preparation solution plus gauze, 2 towels for the baby, sterile abdominal pack, swab, sterile gloves, disposable apron. If not immediately available, you can use disposable. So these are the things which are included in the perimortem caesarean section kit. But these 2 things are essential. Only 2 things are essential. So that finishes the perimortem caesarean section also. Thank you. Any question on today's topic?
No, sir.
No?
No, sir.
No, sir.
Okay. Okay. Thank you.
Yes. Thank you, sir.
Thank you, sir.
Thank you, sir.